Hello, this is your brain on drugs, punk rock psychiatrist here, and I've got, I think, what's going to be a really interesting topic today. And so we're actually going to be talking about SRI-induced sexual dysfunction, and I think this is something that maybe isn't discussed quite as much, and it's something that is of the utmost importance to patients. And it's something I've always discussed with my patients. I know a lot of people in medical practice are uncomfortable broaching the subject of sexual activity. I think, that is a huge miss. Um, it's something, it's like drinking and eating. This is something that pretty much everyone is doing at some point in their life, some more than others. Some put more importance on it than others, but it's definitely a huge thing. And if it's going well or not going well, that can really enhance or impede the mental health treatment process. And I think when we're giving medications, I think a lot of the time what happens is you get the practitioners who, they really feel like the patient needs this medication, but they're really afraid to maybe they're uncomfortable talking about sex, or maybe they're have difficulty, like they think the patient really needs it, and they're concerned that if they tell the patient that this is something that might happen, that the patient might not take the medication, and they feel like they really need it. Let's at least get these symptoms under control first. But I think with anything, for me, I always tell the patients everything up front. I don't want to hide anything. I don't want them to find something else. Because the thing is, patients may not tell you about this, right? If you don't ask, they're probably, I mean, if you feel uncomfortable talking about it, think about them. You know, if this starts happening to them, how comfortable are they going to feel discussing with you? So, when I talk to the patients, I always mention this before I give them the medication, and then I ask them about it after they've taken it. And in fact, if I tell them about it beforehand, they're actually much more likely to bring it up on their own later. I've had several patients that I've inherited that this was never discussed, and when I asked them about it, they were like, "Oh my gosh, really? This medication could be the reason why this happened? I can't believe nobody told me about this before." And you think, patients are going to go on the internet and they're going to search things, but a lot don't, and they don't find these things. And it's not really up to the patient, it's up to us, those that are giving the medication, to explain these things to them. And I think it's really important the way you do discuss it. I'm going to say, this is something that could happen. It's, you know, very commonly happens, but if it does happen, let's cross that bridge when we get there, because we can always take the medication down to a lower dose, which maybe, may help, or change to another medication, or stop the medication. We can always do that. And this adverse effect is highly likely, I can't say 100%, but highly likely to resolve when we withdraw the medication. And so I feel like, let's give it a go, see what happens. If we're having some issues there, there's ways that we can address it. And that's what we're going to be talking about in today's episode. We're going to be talking about this issue, and we're going to be talking about what we can do about it. And, the FDA actually put out a message. I'm not sure, it's not a black box warning, but it was a statement where they said, if you're starting a patient on a serotonergic medication, you need to discuss this with them, because it just wasn't happening. Now, this is not a requirement. This is not something where the patient can be, suing a provider because they didn't do it. But this is a very strong message from the FDA. They're saying you need to tell patients about this, because it's something that's extremely important to most people. And I like I said, I really don't like the idea of hiding things from patients. I want to be upfront with them. If a patient says, I don't want to take this medication because of a potential side effect, that's okay. We're not there to force people to do things. Whenever I meet with my patients, I give most of them a very similar talk where I say, I'm going to be your guide on this journey. I'm not going to tell you what to do, what you have to do, what you need to do. I'm going to listen to you. I'm going to say, reflect back what I'm hearing. I want to get your buy in. Do you agree that this is, if I heard things correctly? And then I'm going to throw ideas out there. I'm thinking about this. I think this might be going on. I think about this. And I want their response. Do you agree? Does that seem reasonable? And sometimes you're going to get a variety of different amounts of participation from the patients. Some patients are going to be like totally in it, like, oh no, that's not at all. That you're not getting it. Or they might be the opposite of, yeah, that really sounds accurate. And you're going to get other patients where they're like, I don't know, maybe, could be. And some patients will be completely not wanting to be engaged in their own treatment. And they'll just be like, you tell me, doc. I don't know. You're the doctor. I'll do whatever you want me to do. And I think all of those are fine because everyone's different. I think, some people might have a negative reaction to the last one that, oh, this person's maybe not as invested in their treatment, but it may just be that they don't have awareness. They don't know. They're coming to you because something's going on and they just don't know what to do about it. And in that case, you can say, well, this is what I'd recommend. And if they say, sure, let's go for it, then go for it. Right. But when I say I want to be the patient's guide, I feel like, basically I'm in between the patient and the medication. They can't access these medications without me. And I'm not there to tell them what's up. I'm there to give them information that they don't have. That they may not understand these disorders. They don't understand how these medications work. I don't just say, hey, let's give you this medication and move on. I tell them how it works, what to expect, when to expect it, how long it will take. I want to give them as much information as possible. And I know some of you, especially those in primary care, you're just like, "Oh man, I do not have that much time." And I think that's where you work on how can you say this as succinctly as possible. Um, I had a mentor when I was a resident, and he told me, and this is kind of related. He said, that he had a mentor that would write like 3 lines, and that would encapsulate whenever he would write his report on a patient. And he was like, that's the goal, to be able to only write 3 lines and say everything. Don't write these like 6, 7, 10 pages of stuff. Just if you can succinctly, the shorter that you can say it, the easier it's going to be for other people to understand and get through it and read it. And I think the same thing with how you present this to patients. The more, the more succinctly that you can say these things, but still get the point across, that's what you want. And that's not easy, right? And I think that's something that as medical practitioners, we have to strive for. How do I convey these messages as quickly as possible while at the same time giving the patient all the information that they need? And this is something that you practice. This is something that you work on. And I think this is something that everyone should strive to work on. And maybe it's something that you never thought about working on. Hey, that's a good idea. And try it out with patients. Try saying it shorter. And when you follow up the patients, you can get that feedback. Like, did that sink in for this patient? Did I said it a little bit shorter? Did they understand that? Or maybe next time I need to say a little bit more. And then you try and I mean, that's what I do. I change my message from patient to patient, and I also kind of tailor it to like how engaged the patient is, kind of how much I feel like the patient's picking up on things. And I'll say, okay, this patient is this type, and so I'm going to give it in this way. And this may sound like a lot to think about, but it's really something that the more you do it, hundreds and hundreds and thousands of times, you get better and better and better at. And I think we can actually go too far where it's like, I know this information so well and I can do it so quickly and so succinctly and so amazing that I actually go through it so fast the patient doesn't even pick up on it, and I'm starting to skip things that I shouldn't be because I'm so bored and I've said this so many times and I'm just gonna blah 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 talk too fast, right? And so I think you've got to kind of catch yourself on either end of that. Am I going too fast? Am I going am I giving too much information? Not enough? And so I think that this is a skill to hone. And in psychiatry, we do have a little bit more time with our patients. And especially when you're a resident, you do have time, especially when you're doing those outpatient clinical time to really work on this because we do give you a longer time to spend with patients. And when you're on inpatient and maybe you're not that busy and you've only got a couple of patients, spend a little bit more time working on stuff like this. And so, I mean, this is a whole topic in and of itself, and I want to use each of the episodes and topics that we discuss to kind of bring up these little, these little sub talks. Um, and so I think it really applies when we're talking about serotonin reuptake inhibitor induced sexual dysfunction, because this is something we absolutely have to discuss with patients, but at the same time, we do have to discuss it in a way to where we don't discourage patients from taking it that may benefit from it. Okay. So let's, and also I call this SRI, not SSRI, right? Because we're not talking about selective serotonin reuptake inhibitors. We're talking about serotonin reuptake inhibitors. We're talking about anything that increases serotonin, right? And I mean, this that would also include MAOIs, even though they're not reuptake inhibitors. Anything that increases serotonin can have this effect. And let's find out why that is. All right. So, arousal, right? So, sexual arousal, and these are kind of our best thoughts on how this works. So the thought is that arousal is based on the in the parasympathetic system. So that's the autonomic nervous system. We've got the sympathetic and the parasympathetic, and typically sympathetic is the turn on, the fight or flight, and the parasympathetic is the kind of tone down, so slow down the heart rate. Whereas sympathetic is increase the heart rate, parasympathetic is decrease the heart rate. And this happens in the gut, this happens in the lungs. Open the lungs, close the lungs. Increase digestion, right? Decrease digestion. We're decreasing digestion actually in sympathetic because we want to put all our energy into fighting or flighting, right? And parasympathetic, we're turning the gut on, right? So arousal based in the parasympathetic system with the chemical acetylcholine. Now, you'll remember acetylcholine when we talked about the tricyclics because they are anticholinergic. Okay, when we say something is anticholinergic, they're actually blocking the chemical acetylcholine. So acetylcholine is having the opposite effects of those anticholinergics. So the anticholinergic, right? That's like makes you constipated, right? It's like the dry as a bone, hot as a hair, right? Remember all those things that we went through? There's a ton of different effects for the anticholinergic. So acetylcholine is actually the thing that the anticholinergics are blocking. Okay, so arousal is based in the parasympathetic system using acetylcholine. And orgasm is based on triggering the sympathetic system using norepinephrine. All right. And norepinephrine, this is the chemical that's involved in the fight or flight. Right. So, I think people think, what's the difference between norepinephrine and epinephrine? Um, if you'll remember from, I think when we were talking about tricyclics, I talked about the prefix of nor meaning normal. It's a a prefix that indicates the metabolite of. So norepinephrine is a metabolite of epinephrine. They have similar effects. Norepinephrine crosses the blood-brain barrier. The blood-brain barrier is that barrier in between. We don't have blood in our brain, but we still have to get nutrients to the tissue of our brain. And so there's actually this barrier called the blood-brain barrier where your blood gets up close to, and the things that we want to get through the blood-brain barrier cross it, and they go into the cerebral spinal fluid that is what, goes around the brain. Blood does not. We don't want blood going through there. That would be bad. And so norepinephrine actually crosses the blood-brain barrier. Epinephrine does not. It works on the periphery, which is outside the central nervous system. And that's kind of the difference between those. And then I think the other interesting where is this produced, right? That's the other thing. So when you think of epi means on top of, nephrin means kidney. So epinephrine, that's your adrenal glands, the glands on top of your kidneys. And if you think about the word adrenal, right? Adrenal, ad means on top of, and renal means your kidney. So one of these terms is I believe from Greek, and the other one's from Latin. So epinephrine and adrenal actually mean very similar things. They mean your adrenal glands, and your adrenal glands produce epinephrine, which turns into norepinephrine, which gets into your brain, and orgasms are based on the triggering of the sympathetic nervous system using norepinephrine. So that's a long explanation, but I feel like it's something that we don't really think about, and a lot of people don't know. Even doctors, they're not necessarily aware of these things, and that's the way I like to teach. I like to get into those details because it gives you an idea of what's really going on. I think it helps me remember the information. All right. So let's keep going. So when you, when you increase serotonin in the spinal cord, this interferes with both of the above processes. So it interferes with the parasympathetic system using acetylcholine that leads to arousal, and it interferes with the sympathetic system using norepinephrine, leading to orgasm. So this is something I didn't know for the longest time. It's like, why does serotonin, people think about serotonin in their brains, people think about serotonin in their guts. And I think maybe people just assume there's serotonin in their genital urinary areas, and that's what's causing this. It's actually the serotonin in the spinal cord that's interfering with these processes. And when we talked about the neuroreceptors, I mentioned that there's a lot of serotonin receptors, 5-HT1A, 1B, 2, 3, 4, 5, 6, 7, right? There's all these receptors. And so dealing with this specific process, the thought is that it's the 5-HT2A and 5-HT3 receptors that are involved. And that's an important thing to know. And the reason why is it can help us pick a medication to help with this issue, or avoid medications to avoid that affect these two areas, right? So it's serotonin in agonizing the 5-HT2A, the serotonin 2A receptor, and the 5-HT3 serotonin 3 receptor. So serotonin lights up all serotonin receptors, all the 5-HT receptors, and it's specifically when serotonin is lighting up the 2A and the 3. And so when we have a selective serotonin reuptake inhibitor, for example, like a fluoxetine Prozac, that blocks the reuptake of serotonin. There's more serotonin in between the cleft in between neurons, and that serotonin is then more available to bind to these 5-HT2A and 3 receptors, which is what causes this sexual dysfunction. So hopefully that makes sense as to why this is happening with serotonin. All right. And the incidence of this is actually quite high. I mentioned in two episodes ago when we were introducing the second generation antidepressants, that although these medications are not as effective as we want them to be to treat depression, they're actually extremely effective in treating um, premature ejaculation. So there's actually 50 to 70% of patients on these medications complain of some sort of sexual side effect. That's more than the amount of patients that are happy that the medication worked for them, which is about a third resolve, about a third respond. So if you add both respond and resolve together, it's about the same amount of patients that will have this side effect. And that's a lot. That's a lot of people. When these medications first came out, and when we talk about Prozac a little later, when Prozac first came out, it was actually on its little package insert where it said, how likely is this side effect to happen? It said 1%. And so we know that not to be true now. And that's why, a lot of these initial trials, these phase 3 trials, they're done on a limited population. And once we give it to millions and millions of people, which is how many people take these medications, we find out, oh, wait, maybe this side effect is more common. And maybe that's because people didn't want to talk about it. Maybe there was some sort of placebo going on, or that was canceling it out because, oh, this is a new med and it's going to work for me. I'm going to have a whole episode on placebo. Placebo is super interesting. It is very interesting, the type of med, the color, the shape, the amount, like all this stuff actually can, and the person giving the medication, there's so many things that influence whether this medication works other than just its chemical structure in the body. Okay. So lots of people get this side effect. And that's why I wanted to spend a whole long episode going through it in detail. It's thought that the two biggest culprits are fluoxetine Prozac and paroxetine Paxil. That's why we often give those to treat premature ejaculation. But you could give any other medication as well. May also be effective for that. And what types of sexual dysfunction is there? All right. So most commonly, delayed ejaculation, or a lack of an orgasm, or delayed orgasm. So that's the thing I hear the most common is patients just say it takes them a lot longer to finish. It's a lot harder to get there. And they may not get there every time, and they may not get there at all. That's the most common. Next, it can affect libido. All right. So just interest in sex. They just may not care about that. And that may be some of the cognitive dulling that's like another side effect of these medications that's leading to that impaired libido. It may be the fact that they just don't get as much sexual satisfaction. And so the reward pathway is just kind of shut down, like, oh, why should I engage in this? I don't really feel anything anyway. And that's a subconscious thought. It's not, oh, you're not just thinking that. It's more like that's your experience, and therefore you may not even, a lot of patients don't even realize it. They're like, oh yeah, I am less interested in sex. And sometimes patients realize it and they're like, I hate this. Why am I less interested in sex? And some of them, they just don't notice and don't care, and it's the partner that complains. I had a patient that he was engaged to somebody, and she thought that he was cheating on her because he was having this he had lost interest, and she thought that he lost interest either because he was having sex with somebody else and therefore didn't have, the ability to be with her or the interest to be with her, and she left him. And here's a great example of, someone who wasn't told that he wasn't told this, and he lost a relationship because of the side effect that he didn't even realize he was having, and he didn't know why he was having it. And so he was unable to give her any kind of explanation. If he had had this, like, he could have brought her into the appointment, and I would have said, oh yeah, this is absolutely something going to happen, and let's do something about it because it sounds like this is a big deal. It's not a big deal for everyone, but it's a big deal for a lot of people, if not most people. But you know if it doesn't bother you, then let's not worry about it. I mean, I tell patients about this and they say, oh, I don't care, it's all right, I'm not with anyone, I don't care if I am or not, I just want to feel better. So you get those patients, and then you get the ones that are like, oh, I don't know if I'm going to be okay with it, but let's see what happens. And then you have the patients that are like, I'm not taking this. Okay. So delayed ejaculation, delayed orgasm, impaired libido, and then also vaginal dryness. So that may be an effect of just having decreased libido in women, and then erectile dysfunction. So that's the least likely to happen. Typically, it's just that they lose interest. but you can have erectile dysfunction as well. And I also want, when I mention vaginal dryness, I also want to like highlight women here. This is something that I think men are a lot more comfortable talking about sex than women are. And as a male psychiatrist, I feel like men are more comfortable talking to me about it than my female patients. You know, if you're a female provider out there, you may be getting the opposite response. You know, maybe the men, there's going to be men that that they're boastful and they enjoy talking about their sexual exploits that may be almost provocative in the way that they talk to women providers, which is inappropriate, and you have to shut that down. But you've got those men that are like, oh, I love talking about my sex life with this female provider. And then you've got other men that are embarrassed about it because like, oh wow, man, I'm embarrassed that I'm having this problem, and like I feel like less of a man, and I don't want this woman to know about this problem because I feel like I'm being judged by women. And so all patients are different, and you have to like go into it not knowing what patient that is in front of you, and learn that about them so that you can address them in the way that will suit that patient. So my experience is that most women don't feel comfortable talking to me about it. And I have some female providers that I've spoken with, and they don't they find that women are a lot more open. I feel like women are a lot more open with them on average. But like I said, you could have the opposite response where they're more comfortable with, some people are more comfortable with the opposite sex than they are with the same sex. And, it's gender comes into play, right? It could work one way or the other way, or not any way at all, but it is a factor. And so I'm always careful to definitely mention this to the female patients, especially because they may be less likely to bring it up to me. I don't want to make them feel uncomfortable, but I want them to feel comfortable discussing this with me. Because, I mean, the worst thing that's going to happen is that it affects their relationship in a negative way, or affects their mental health in a negative way, and it hasn't been addressed. And then I've done more harm than good. Okay. So that's what happens and how it happens, and kind of how many people it happens to. Let's go through the next series of slides are all about what to do about it. Okay. And there's a lot here. Okay. So, one is we could switch antidepressants, right? These are our techniques. What all can we do? And there's a lot of things we can do, but there's limited evidence for almost any of it. This first one is the best one. Switch. If they're on a serotonergic medication, you could try bupropion. It doesn't have the serotonin effects. It's a norepinephrine dopamine reuptake inhibitor. So I often give bupropion first, and we'll talk about that when we get more detail of the meds. But I like it because of that. It tends to work about as well as the serotonin medications. It has a different set of side effects, but it doesn't have this side effect. And so you could think about starting with that to begin with, especially if you've got a patient who's like, I don't want to take this. Well, offer them bupropion. They don't have to walk away taking nothing. Or if they had this side effect, switch them to bupropion. Mirtazapine, Remeron, that's another option. It actually blocks these receptors. It doesn't increase serotonin. It increases serotonin at some receptors and blocks it at others. And the ones that it increases at don't affect sexual functioning. And the ones that it blocks are actually the ones that it would affect if it were not blocking them. So, but it does cause a lot of weight gain and sleepiness. And so that's why between the two, on the average patient, I'm going to pick bupropion over mirtazapine, but it depends on the patient in front of you. Trazodone's actually another one, but it makes people extremely sleepy. But I've got patients that don't feel sleepy on trazodone. And so that's another one that doesn't have that sexual side effects from serotonin. So you could switch to one of these other medications. And there's actually newer medications coming out now that don't affect this as well. And we'll get to those at some point. So that's technique number one. It's the one that I favor the most. The next thing is a drug holiday for 2 to 3 days. these medications have a half-life of about 24 hours, but when you're at steady state, it takes a few days for the medication to get completely out of your system. I don't like I don't like this technique, a drug holiday. This would be like, because these medications are meant to be taken every day. Not all patients do that, but they really don't work very well if you don't take them every day. And the withdrawal, which I'll talk about when we go through some of the adverse effects of these medications, the withdrawal can be bad. But this is an option if you're, not looking at having that many sexual events, whatever you want to call it. If it's like once a month kind of thing, maybe taking a couple of days off of the medication for that once a month to have a satisfying sexual encounter might be an option. And so this is not most patients, but to be honest, a lot of patients are skipping days on their meds anyway. And if they're going to skip days on their meds, why not skip it to avoid this side effect? So it's something that could be considered, but as a psychiatrist, I don't typically recommend it. But if I've got the patient basically saying they're going to do it anyway, I want to give them the information on how to do it, with at least what to be aware of. These are the withdrawal symptoms you might have. So, be careful with those. Um, so they may have withdrawal, and it decreases the efficacy of the medication, and it also could worsen their noncompliance. If I'm giving them license to not take a medication that they're supposed to take every day for it to work, then they may skip it on other days too. And then we're really having that problem. So for all those reasons, I really don't favor this, but there might be the patient out there that this is the technique to use. Next, testosterone. This is one that you may hear of or the patients may ask about. I don't like it. So for women, maybe. For men, I really do not recommend doing testosterone. And we have very clear guidelines. Testosterone needs to be checked between 8 and 10 in the morning, 3 low values. I see this happen all the time. The labs are checking me at the wrong time. You have to tell the patient, and I'm sure urologists out there are not making this mistake, but psychiatrists, we often are looking at testosterone. You have to know what time for them to check it. It has to be in the morning, and you need it may be 2, but it's 2 or 3 low levels before you can definitively say that there's an issue here. So I only want to give testosterone to patients who have low levels and they have symptoms of hypogonadism. So that's not, I mean, if you're having sexual dysfunction because of a med, that's not hypogonadism. Hypogonadism means decreased functioning of your testes. Okay, it that this medication does not cause that. It causes a side effect, which is one of the criteria of having hypogonadism. Um, and so if they're having this with the med, you'd want to say, well, did you have this problem before you took the med? And are you having other symptoms of hypogonadism? Okay. And are your levels of testosterone actually low? So testosterone is not something that's going to combat this side effect. It's something that's going to treat a completely separate condition. All right. And for females, I'm going to go into more detail later, but there is a substance called estrotest that's used for sexual dysfunction postmenopause. We're gonna touch on that and some other options for women. I've got like 2 good slides on that. Next, so we've discussed that there's 3 chemicals involved here. Serotonin's involved, norepinephrine's involved, and uh, acetylcholine is involved. So the the possible things that we could do to help with this side effect would be acting on those symptoms. So let's go through those. First, let's start with serotonin. How can we combat what this serotonergic medication is doing to serotonin, which is causing this side effect? One option is to give them a 5-HT1A agonist. Okay, so actually increasing serotonin 1A receptors helps with this side effect. Whereas, remember, it was 2 Let's see, which one was 2A and 3 are the ones that are harming it. And so there are some 1A agonists out there. Buspar is one of them. I've done this. I don't see it working that often. I have had a couple patients that adding Buspar fixed their problem. So this, I feel like, is a viable option for a small number of patients. Because I can say that it has worked, I would say it's something worth trying. Okay, if it's another option that's worth giving a go. Um, Buspar, 15 to 60 milligrams a day. There's limited evidence. It's Buspar also has some alpha 2 antagonist activity, and then remember that works on norepinephrine. So there's two things that Buspar is doing that may be helping with this side effect. And then there's the newer antidepressant Gepirone. I have not. It just came out. I haven't had an opportunity to give it to anyone. I don't know anyone that's ever taken it. I've read a lot about it. We're going to discuss it later. It doesn't look like a great antidepressant, but you know, if Gepirone works for their depression, that would be another option, kind of like bupropion is, as a medication that's not going to cause this side effect. But like Buspar, it's one that could be added to combat the side effect. And then vilazodone and vortioxetine are two serotonergic. They're SSRIs plus other activities. They're plus they also have 5-HT1A agonism, and they've been purported to have less sexual side effects. I don't really buy it. I think it's a case of the fluoxetine, having the 1%, and these, in their initial trials done by the companies that make them, showed similar things. Well, Prozac showed that too, and now we see that it's like 60%. And so, you know, you could try vilazodone or vortioxetine because they have this 1A partial agonism, but they're also SSRIs or SRIs. So they also increase serotonin. So they cause this side effect, but then they have a component that may combat it. But really, if adding Buspar to an SSRI is not going to work, these aren't going to work either because they're essentially Buspar plus an SSRI. All right. But like I said, they probably have less incidence of sexual side effects than the SSRIs. And I think they're off patent or close to it by now. They came out when I was a resident, so they were expensive, and I never used them because in the military system they're really careful with the money, and we try not to go off label, especially when we have a ton of other options. But I would get patients that were seen by outside providers, and they'd come into the hospital and they'd be on these medications. All right, so that's the 5-HT1A. Now let's look at anti-serotonergic. So remember, 5-HT2A is what's causing the side effect. Well, if we antagonize that receptor, so if we have a drug that latches onto that receptor, doesn't do anything to it, it basically just grabs it so that serotonin can't. So serotonin can't have its effect on that receptor because this med it's on it, but it's not turning the key. And I'm going to go into detail on all this kind of antagonism, agonism, and partial agonism in another lecture. But the way I think of a blocker is it's like sticking gum in the keyhole. You can't get the key in there, but you also can't open the lock. All right, that's a blocker. An agonist is the key. It goes in the keyhole. It turns the key. We open the door. That's what an agonist does. So if we block that 5-HT2A, that might help. The unfortunate thing is blocking 2A also causes sedation. And so making somebody sleepy, all the time, especially if it's acting 24 hours a day, could be a problem. So ciproheptadine, this is actually a medication that's been given for serotonin syndrome. So it's like it blocks serotonin to try and get, those receptors free to, I don't know that it actually works that well for serotonin syndrome. It used to be used a lot. I don't know if it's used as much now. You could give ciproheptadine 4 to 12 milligrams, 1 to 2 hours prior to sexual activity, but this is kind of going to have the same effect of taking the drug holiday. You're kicking the drug off. It's not having its effect because ciproheptadine doesn't just block 2A. I believe it blocks like most, if not all, of the serotonin receptors. Then you've got mirtazapine. We already talked about that before. Um, you could add mirtazapine to, you can take mirtazapine with an SSRI. We often combine two medications that have different mechanisms of action. So rather than just giving mirtazapine, say we're taking, you know, fluoxetine or escitalopram, and it's having a great effect, and mirtazapine by itself doesn't, but combining, so we don't want to switch to it, but maybe it helps with the sexual side effects, and we take both at the same time, and it has a little bit of enhancing on the mood as well. So you could switch to mirtazapine or you could add it. And then trazodone also, you could add trazodone, but it does cause a lot of sleepiness. Flibanserin, we're going to talk about that in a later slide. That's a newer medication that's come out. It's a 5-HT2A antagonist. And then 5-HT3 antagonism, right? Because it's 2A and 3 that are causing this problem. So the ones that block 3 are like your Zofran, ondansetron, or granisetron. So I've got here that granisetron has been studied 1 milligram 1 to 2 hours before. There's limited evidence that it works. It seems kind of weird that, like, if this is how these meds work and we block this activity, it should fix the problem, right? Well, I mean, I think this just illustrates the fact that we don't 100% know how this works, because this should help. But, if you're grasping at straws, there is some evidence to give granisetron. I've never seen it done. I've never done it myself. I'd be interested to see. And maybe the studies that have been done on it haven't been that robust. It's a possibility. But I mean, you're blocking that 3, but you're not blocking the 2A. So you need to block them both. All right, moving on. And remember how acetylcholine is also involved. So let's talk about drugs that work on that are cholinergic. So rather than anticholinergic, they are cholinergic. So procholinergic or adrenergic. So bethanechol, 30 to 100 milligrams as needed 1 to 2 hours prior to sexual activity, is something that has been studied. Neostigmine, 50 milligrams as needed 1 to 2 hours prior, has been studied. I've never seen it done, never done it myself. Just like I don't want to cause anticholinergic side effects, I really don't want to cause the opposite cholinergic side effects. And the studies that were done on these, limited evidence. And remember, the cholinergic system is just involved in arousal, not involved in orgasm. And orgasm is typically the problem that we have more often. So probably not worth it, but these have been looked at. It's been studied. It's something that maybe in certain patients could be tried, but not looking great. And then, right, norepinephrine is the last one that's involved. So what could we use to possibly combat that problem? So you could take something that's a norepinephrine reuptake inhibitor. So if the serotonin is modulating the norepinephrine to be lower, why don't we take something that could increase that? So this is where we talked about a couple episodes ago about bupropion, and I would say bupropion added to an SSRI or SNRI is probably the most common thing done that I've seen for sexual side effects. I don't particularly like this. I think it's reasonable, especially if you have, maybe their mood is not as good as you wanted it to be. Bupropion with an SSRI, that's a great combination. If you're going to combine two medications to help with mood, it's a good option for that. And so it may also have this effect of combating that side effect. But like I said, um, I've seen it help, but it's not like super great at it. But definitely this is one that I would add to the definitely worth a go category. And using the IR formulation might be more useful when you take an IR. Bupropion IR has to be taken 3 times a day. But if you were just using it for this, perhaps just taking that IR once a day might help. But most people are having their sexual activity in the evening. Bupropion tends to make it hard to sleep. So if you're taking your dose later, like an IR, that could be a problem. So something to be aware of. Another set of medications to increase norepinephrine are the stimulants. So these are our ADHD medications, our methylphenidate, amphetamines, dextroamphetamines, right? You could do this a couple hours before, but once again, we are going to want to avoid this at night. So if you're a morning sex person, maybe an as needed stimulant could be an option for you. If you're a later in the day kind of person, I would definitely avoid this. These are also Schedule 2 controlled substances, so probably shouldn't be at the top of your list. But if a patient has ADHD and they're a morning sex person, hey, maybe everything's lining up for, trying this. Or maybe they're not a morning sex person, but you could say, hey, you could try being a morning sex person, and try one of these medications. All right. What's another thing about norepinephrine we could do? So I already mentioned it. Alpha 2 antagonism. Remember, Buspir's got a little bit of this effect. Mirtazapine has this effect too. When you block alpha 2, you increase norepinephrine. So mirtazapine, once again, is a good option. Um, and then when we talked about the neuroreceptors, remember, when you blocking alpha 2 and agonizing alpha 1 kind of have similar effects. So agonizing alpha 1 decreases blood pressure, antagonizing alpha 2 decreases blood pressure. So this is something you also have to watch for when we're doing this, is you could be lowering blood pressure. So block alpha 2, mirtazapine, increase norepinephrine. Now let's look at agonizing alpha 1. We could use, so these are all things that have been looked at. So midodrine, 7.5 to 30 milligrams, 30 to 120 minutes before. Imipramine, that's a tricyclic, remember, 25 to 75 milligrams before bedtime. Ephedrine, I don't know why anyone would give someone ephedrine. I think this is just something that was studied. 15 to 60 milligrams an hour before. Pseudoephedrine, 60 to 100 milligrams 2 to 3 hours before. Systemic pseudoephedrine, that's pretty much a prescription medication. I don't really like any of those four. I think the side effects outweigh, I think the cost outweighs the benefit there. But, we're going deep. We're talking about every single possibility in this podcast. And so I want to, just highlight that these are things that have been looked at. All right. Now we've moved through serotonin, acetylcholine, and norepinephrine. There's a couple others. So dopamine. Dopamine modulation can actually help with this as well. And that's where, bupropion increases dopamine, may be helpful. But there's some dopamine agonists, pergolide, 0.25 to 2 milligrams a day, pramipexole, 0.125 to 1 milligram 3 times a day, ropinirole, 0.5 to 1.75 3 times a day, bromocriptine, 2.5 2 to 3 times a day, cabergoline, 0.5 twice a day. Now, or twice weekly, sorry. I wouldn't. I don't like these dopamine agonists. We give them for restless leg and Parkinson's. We see a lot of it's interesting when we give these to Parkinson's patients. Often, what happens is they'll take a lot of risks. They might become hypersexual. They may become they may start gambling, may lose all their money. And these are actually things that were starting to come out. This was about 10 years ago that there were news reports coming out about that. So I don't think it's worth using these, and I don't know that they're that effective for this particular side effect. And, I actually had a Parkinson's patient. He was so hypersexual that he was masturbating in front of the nurse when she would come in the room, and he wasn't demented. He didn't have dementia. He was cognitively with it. He was a high IQ, very intelligent man. I had very good conversations with him, and then here he is masturbating in front of the nurse. Okay. And it's because of all these dopamine enhancing medications he was on. So dopamine, this is where your stimulants and bupropion might be a better option than these dopamine agonists. And then one more that affects dopamine. So presynaptic dopamine release and inhibition of dopamine reuptake postsynaptically, imantinine does that. 100 to 200 milligrams twice a day, 2 days prior. Limited evidence for this. Next, oxytocin. So that's like the love hormone. That's the hormone that happens, that is when babies are born. Um, that this is actually an analog of this is given to help induce labor, pitocin. It's given when babies suckle on their mothers. It helps with baby and mother bonding, but we've actually there's been studies that have shown that men's oxytocin increases to enhance their bonding with the baby, and of course they're not breastfeeding their children. And it's also oxytocin levels go up when couples have sexual intercourse, and so I found some studies, oxytocin 16 to 24 international units intranasal during, I guess this is like right about before while you're like having your um, kind of your pre-sexual activities, or sublingually. And so it acts on peripheral oxytocin and or vasopressin receptors. I don't know how well this works. I don't even know that this is an option to prescribe this. This is more kind of something that maybe could or should be studied. And then lastly, or it's not lastly, but lastly on this group of treatments, let's talk about topicals. So if vaginal dryness is an issue, there are estrogen creams, there are lubricants, there's some over-the-counter topicals. Zestra and Galaxis are two for women. Um, they've got a lot of essential oils and things and massage oil type of stuff in them that's supposed to like enhance that ability. And so that you could give those for if you're having difficulties with sexual libido and so forth. It's something that these are very low risk that you could use possibly, and that patients could buy over the counter. And there's actually a new one for men that just got approved last year. It's called Eroxon. Sounds like erection, get your rocks on. I don't know. It's an interesting name. It's an over the counter topical for men. It contains like some alcohols in it. It like kind of like what you'd use for like back pain or something, like a Solumpus type of thing, where it like causes like cooling and warming. It's supposed to stimulate the nerve endings in the penis to help with arousal and so forth. So this was actually just FDA cleared last year, 2023. So it's available now. I believe you can order it on Amazon. And I mean, the good thing about it is, unlike a lot of things that you can buy over the counter, there actually is some evidence behind this helping, specifically in serotonin induced sexual dysfunction. No, but in just men that have libido or erection issues, those by themselves. So might you want to try this if you have the serotonin induced type? I mean, it's worth a shot. I would say it's very low risk. There's no systemic absorption. There's no interactions. The side effects are going to be like almost nothing, and it's cheap. If it doesn't work, it doesn't work. You don't have to use it again. But I think it's something that if a patient's interested in it, or if they're interested in taking something that's more natural or topical, I think as physicians, we need to be aware of everything that's out there. So something that you could consider. Um, Next, I want to go into a related topic called hypoactive sexual desire disorder in women. And the reason why I want to talk about this is because I want to talk about fulbanserin. Remember, I mentioned fulbanserin was a 5-HT2A antagonist. It's also a 5-HT1A agonist. So you'd think, oh my gosh, this is like an amazing medication. And it was approved in 2015. Its brand name is Adyi. I'm not even sure how to pronounce that. It's ADDYI. And so it's got this two functions that might mean that it works. Unfortunately, I can't really recommend it. I've never seen it used, but I've I, I've listened to a talk by an OB-GYN doctor, and she was not thrilled with it. And one, it doesn't work that well, and there's a lot of negative effects. So there's an increased risk of dizziness, somnolence, sleepiness, nausea, and fatigue. And it's actually a black box warning. But it's got a black box warning for low blood pressure and fainting when combined with alcohol, a moderate to severe CYP P450 3A4 inhibiting medication, or a patient with hepatic impairment. So I guess if you're not taking a 3A4 inhibitor or have hepatic impairment or drink, then this risk is not to the point where you'd have the black box warning signal going off, but you actually have to do a RIMS with this, which is not great. RIMS is not that RIMS is a bad thing. It's just it's something we do it with Clozaril, clozapine. Um, there's a handful of medications that require this. Qsymia is another one, weight loss medication. I'm trying to think of the meds that I would use that have RIMS requirements. It's an extra step that you have to do some sort of specific thing in order to get the medication prescribed. And for Clozaril, it's checking for your neutrophil count. For Qsymia, it's just reading some guidelines to the patient, and the same thing for this. But the thing is, your pharmacy has to be able to be certified in RIMS for this specific med. In the last hospital I worked in, they weren't able to do RIMS for Qsymia. So if I was going to prescribe Qsymia, I had to have the patient get it not at my military facility because we couldn't do the RIM. We hadn't gone through whatever process to get it. So the pharmacy has to be able to have this. It's pretty simple. It's just a medication guide that explains the risk of the medication. But here's the bottom line. There's limited evidence. When you look at the study that this medication, flibanserin ADE, was approved for, it was shown that there was 1/2 of an additional satisfactory sexual encounter per month. That's not great. And remember, this medication is FDA approved for hypoactive sexual desire disorder in women, not serotonin induced sexual dysfunction. But I want to rope this stuff in there too, because, theoretically, this is a medication that works similar to some of the ones I mentioned. And I mentioned it in the list before. But 1/2 additional satisfactory sexual encounter per month, and a RIMS requirement, and a black box warning, and dizziness and sleepiness, nausea, fatigue. If you take this medication, you love it, comment down below. I'd like to know, because I have not met anyone that is thrilled about this medication. Or if you're a provider and you've given it to patients and you feel really strongly that it's worked in a few people, comment down below. Okay, so we're still talking about hypoactive sexual desire disorder in women. Remember, this is a different condition. This is just, once again, this is another syndrome condition where we don't really have clear evidence. It's something it's not something that's been written down about as a specific disorder that long. I would say no more than 10 to 20 years that the specific disorder has been out there. If I'm wrong, somebody let me know. But it's a disorder where basically in women that they have decreased interest in sex. And it's not because of a med, it's not because of, their partner or whatever. It's not because of anything we know. It's basically idiopathic. It's basically we have no idea why this is happening. And so we've ruled everything else out. We lumped you into this category of hypoactive sexual desire disorder in women. And it's a big issue. I mean, a lot of women do have this. And so I think it's important to find treatments for it. I don't really think that flibanserin is the answer. Let's look at some others. Next is bremelanotide. Its brand name is Vyleesi. I don't know how to say that either. Vyleesi. Not sure how that's pronounced. It came out in 2019. I don't watch a lot of TV, especially the kind of TV with commercials. I heard that there were a lot of commercials on TV during the Super Bowl about this, and maybe it was just like being blasted on TV as like something to take. And so sometimes I think patients might know more about some of these medications than doctors do, because if something's not that effective and not that great, we're not going to hear about it. Like, I'm not going to hear about something that's not great, but the drug company wants to sell their product. And so they may do a better job advertising to the patient than they do for the doctor, because the doctor's going to read about it and be like, oh, this doesn't look that great, I'm not giving this. This isn't, this medication is not unlike the previous one we talked about, where it's not that great and it has a bunch of side effects. So the OB-GYN doctor talk that I listened to on this, she was not a fan of this either. She basically doesn't recommend this to any of her patients. So what is it? So it's a non-selective agonist of the melanocortin receptors. So this is a receptor class that we haven't talked about. You've got melanocortin melanocortin 1, 2, 3, 4, 5. And so I guess non-selective means it binds to all these. I'm not that familiar with this receptor. I think there's a medication for diabetes that could be used for weight loss that affects this receptor. And when we talk about weight loss, I'll talk about that one. And it has the same ending, right? This is bremelanotide. I think that one's like similanotide, or it starts with an S and ends in a lanotide. So it works on these receptors as well. So this is actually also given subcutaneously. So that means the person gives themselves a shot, kind of like an insulin shot in their subcutaneous fat, usually on their belly, 1.75 milligrams, 45 minutes prior to sexual activity. In the studies that studied this, there was a percent of satisfying sexual events increased. Not very specific, a percent, but also, even though there's this percent of satisfying sexual events increased, there were 0 additional satisfactory encounters. So I guess they said that there were more satisfying events, but there were no additional satisfactory encounters. I don't know how to parse that together. It does seems like it doesn't make sense. But my guess is that percent is so freaking low that it basically adds up to 0 per month additional. Um, there was a decrease in distress related to desire. So I guess there was a tiny decrease in distress related to the desire, but 0 additional satisfactory encounters. That's not very amazing. So I can't really put my stamp of approval on this medication. Next, esterified estrogen and methyl testosterone. This is the estra test. Remember, I mentioned this before and I was going to go into more detail later. We're getting more detail later. All right. Estra test. It's estrogen and testosterone, esterified estrogen and methyl testosterone. So, what the heck is this thing? So, it's FDA approved for vasomotor symptoms associated with menopause. And I'm going to go into a lot of detail on that at the end of our depression series when I talk about menopause. So this is one of the medications. Remember, Paxil is approved for this. This is the second one that we've encountered so far. Estratest is also approved for that's hot flashes. So it could be used off-label for hypoactive sexual desire disorder in women. So not even approved for that. It's been in use and available since 1964. However, and there's a big however, 5, count them, 1, 2, 3, 4, friggin' 5 black box warnings. That's a lot. That clozapine has 5 black box warnings. In fact, I mean, methadone, I always think methadone's got 10. Clozapine's got 5. That's the next most that I know. I think some of the opiates have a lot. The opiates have around 5 or so, depending on which opiate it is. But this one's got 5. Holy crap. So increased risk of endometrial cancer, increased risk of cardiovascular disease, or risk in cardiovascular disease because it could cause cardiovascular events, increased risk of breast cancer, a warning not to use while pregnant. So, I mean, those are all risks that we see in birth control pills. And so this is not totally dissimilar from birth control pills. It contains the estrogen, but without the progesterone on top of it. And it's got the testosterone in there. I don't like the sound of this. As a psychiatrist, I'm certainly not doing this. If this is something to be considered, I feel like this is completely in the wheelhouse of OB-GYN. I'm not giving somebody estra test. I'm not even going to think about it. And then the 5th black box warning is risk versus benefit. So they're basically saying, does the benefit really outweigh the risk here? And, I don't have data on how effective this is. I think OB-GYN would be way better at handling questioning on this. So related to that, though, is testosterone. Remember, we talked about testosterone for men and how I don't want to give men testosterone unless they have hypogonadism. Now, for hypoactive sexual desire disorder in women, there's actually some reason to do this. So let's talk about testosterone in women. Now, women at baseline don't have very high testosterone levels, right? We want to test their testosterone, but we're using it as a baseline, not to be like, oh, your testosterone is too low, you need testosterone. No, we just want to see what it is because we want to make sure that it doesn't get too high if we give them testosterone, right? So we check it, not to check to see that it's too high or too low, just to get a baseline, all right, so that we can track it. And we also want to make sure that they're not at a really high level already. We're not really concerned about whether they're too low. I said that wrong. We're not concerned if they're too low, like it would be for a man, but we are concerned if they're already high. If they're already high, we don't want to give them more. All right. So in the vein of this, there are actually products out there that people can get without a doctor's prescription that are called these compounded bioidentical hormone therapy, or little c, big B, big H, big T, CBHT. So this is something patients might find a way of acquiring. Um, and not a fan. Not a fan of this. I'm never a fan of like these like shady, try to put it together type of medications that might work. That the doctor's really not supervising, and the FDA is not really putting their eyes quite as much on looking for safety stuff. Like they're just, I mean, say what you will about the FDA and how they prescribe, do what they do, but like what I would be even more worried about is something that's outside of the FDA, right? Then we're not getting any look on safety and what's in there and what components are in this product, right? So the, these compounded bioidenticals testosterone, they often include topical progesterone that's ineffective for what we're doing, and it exposes them to risk of endometrial cancer. Next, there's often too much in there. And so then we're exposing the patient to super therapeutic doses. And if they get too much testosterone, because it's not well regulated how much is actually in this compounded product. So if you're getting too much, it could cause permanent facial hair, deepening of voice, clitoromegaly, that's an enlarged clitoris, and cardiovascular harm. Not good, not good, not good, not good. And it get super physiological dosing. So this is your levels of testosterone are too high in your body. So super therapeutic would mean like the dose in the medicine is too high. Super physiological would mean that the amount in your system is too much. So super physiological dosing um, of this product is often required to achieve the strength, weight loss, and energy. And to get that much, it's just not worth the risk. Okay. So patients, please don't do this. Prescribers, if patients are doing this, um, tell them they're going to get might get permanent facial hair, deepening voice, clitoromegaly, and cardiovascular harm, and they'll probably stop. Okay, but we can't. All we can do is inform. You're not. Don't feel like you're responsible for everything. That's why I said I guide the patient. I give them the information. We pick something together. We pick a path together, and then but I'm there to give them the information they don't have. I'm there to get through the web to translate the WebMD to them. I'm there to tell them that this study they wrote about was not scientific. I'm there to tell them that this study that they never saw and didn't understand, that didn't know how to have access to, actually gives us the information that is more valid, right? I'm there to give them better information, and we'll make a decision together. I won't let them do something that I feel is unsafe, and they may not pick what I would pick or what I would even recommend for them given what they've told me. But if they pick something that is on my safe list and we've talked about it, I'm going to let them go ahead and do that, and I'm going to give them the medication. That's how I like to practice. We make the decision together. I don't I don't do anything that I feel is not safe. I give them the information. I let them make it, or we make it together, or they want me to make it, whichever, is the patient's prerogative. And we go with a safe option that is, I'm not going to give them something that I think is completely not going to work at all. Um, and I'm not going to give something that I think is dangerous. But, I'm going to let them make the choice amongst what options I give them. Okay. And so I'm going to discourage them from doing things like this because they can do this without me. and I don't want that, but all I can do is give them information, but they have their own agency. I'm not paternalistic over them. I want them to own their own health. Um, Ultimately, I'm there as their guide. Okay. So going on with testosterone. So, low doses of testosterone can actually be safely used for hypoactive sexual disorder. I've seen it done. I've talked to an OB-GYN. An OB-GYN that I spoke to directly gave me a research paper on it. She told me how she does it. I actually feel comfortable doing this. Whereas, the Vyleesi or whatever, I'm like, nope, ester test or whatever. No, I'm not doing this. But this is one I would consider. I haven't, but I would consider it. I just learned about it like a year or so ago, so I just haven't had the opportunity. But I feel like if the right patient came along, this is something that I would personally feel comfortable doing. But all physicians need to kind of know where they feel comfortable doing. You maybe feel comfortable doing things that I'm not comfortable doing, and vice versa. So, if we're going to do this, how? So, we want to do 300 to 500 micrograms per day. This is actually can be challenging because you can't order that dose. That dose is not orderable. Giving testosterone to women is not something that's just out there to prescribe. Um, this is 1/10 of the dose that would give to a male who had hypogonadism. So you would have to give them the same product, the gel product that we give to males, and tell them, try and divide out. And this is going to be like a little foil package, right? With it's like double-sided foil package with like the gel inside, and you rip the top across and you squeeze the gel out. We're going to have to make sure that they can like measure, try and just get 1/10 of that out. Just squeeze 1/10 out, put that on your thigh, and um, another 10th the next day. It's pretty hard to do. That's why I would be like, how comfortable do I feel like doing this? It's a little challenging, but there actually is some pretty good evidence that could be helpful. So, um, so if you're going to do it, you got to do that the gel tube, 1/10 of the dose for males, 300 to 500 micrograms a day. We need to make sure their estrogen levels are normal, so we got to check that. And then we want to check anytime we're giving testosterone, men or women, or uh, uh, women that are transgender and changing to male, or sorry, not changing to male, but they're going through transition hormonal therapy. Um, we're going to want to monitor CBC and lipids. So anyone we're giving testosterone to, whether it's transsexuals, men, women, whoever it is, we got to check CBC and lipids. And for females, we're checking estrogens as well. And then what you're going to do is you're going to calculate the FAI, and what the FAI is it's total testosterone divided by sexual hormone binding, or sorry, SHBH, sexual binding hormone. I forget what that first H is. But this is a blood test. So we get the total testosterone divided by SHBH times 100, give us a percent. And that FAI, which is an index, should be 1 to 5% after they've gotten the treatment. So we're giving them this 1/10 of the gel thing, and we calculate that, and we want it to be between 1 and 5%. So it's not super easy to do, but it is doable. Okay, so this is an option that's out there. All right, now we've talked about basically all these treatments that aren't that great. And I mean, kind of to summarize, switching medications to something that's not serotonergic is probably your best bet. Adding something like a bupropion or a buspirone or a mirtazapine is probably your next best bet. Most of the other stuff that I've talked about, not that great. If it was happening if it's not associated with the medication, making sure that if it's a male that we're not don't have the hypogonadism, that's something to also be looking at. But outside of that stuff, Most of those other treatments, I'm just not going to do. But what I do regularly do is give a PDE5 inhibitor. So a phosphodiesterase 5 inhibitor. This is Viagra.